Welcome back to Zooming In with Zali. Sadly, we are in lockdown again, and this is the best way I can get more information out to residents of Warringah and further afield who are following on Facebook. We're incredibly lucky to have Professor Mary-Louise McLaws here in Warringah to give us some advice and some insight into what's happening, because I know the level of frustration and anxiety is rising as the emotional and the personal impact and the economic impact of the lockdown really starts to bite. I'll start off by paying my respects to Indigenous elders, past, present and emerging. May we work together to take better care of our beautiful environment and land. Mary-Louise, thank you so much for coming on again. How are you?
Thank you, Zali. I'm well. I'm in lockdown, as we all are, and I feel everyone's pain. I'm fortunate enough to be able to work from home, but there are many that can't, and they're feeling a lot of anxiety about their businesses and their income. So it's and of course mental health, staying away from their friends and family. So it's a tough time for people.
Absolutely. Now, I guess from my point of view, we're trying to get as much information as possible. I'm watching the 11 a.m. Press conferences religiously to get the update. And I have to say, personally, it does feel a little like Groundhog Day. We're seeing 140, today was 145 cases. We've had those kind of high numbers for a few days now. And we seem to have consistent numbers between 30 and 60 infectious in the community. And that number doesn't seem to be going down. And my understanding is that is something that needs to happen for us to have a light at the end of the tunnel of lockdown. And we have high numbers of testing occurring. It really kind of gets, I guess, frustrating for people to try and understand if what we're doing working? Should we be doing more? What else can we be doing? Could you explain it to us in layman's terms so everyone can really get to the bottom of it?
Sure. So the proportion that I look at is those that are not in full isolation at the time of their diagnosis. Partial is not good enough, and under investigation suggests to me that they've probably not been in full isolation as well. Otherwise they'd know, because they'd be family members. So that number has not been declining sufficiently enough. And as we've been saying right from the word go, that has to be zero, so that we know that, sadly, those that are in household clusters will grow, because Delta is about 1,000 times more infectious for the individual to spread it, because you build up more a viral load than we've ever seen ever before. So the number of that proportion of people who haven't been in full isolation has not been going down. In fact, it's been trending up, but we've had two false peaks where I've got slightly excited, but then of course I've got just as depressed as everybody else. I've been using a rolling 3-day average for that proportion, because the incubation period appears to be 2 days shorter than it's ever been before. I've also done the usual 7 days. That 7-day one only works well with big numbers. So we had a false peak on about the 12th of July. And then yesterday on the 24th, so Saturday, we had another false peak. And it looks as if we're declining, but remember, today's numbers actually represent Sunday's numbers, and Sunday's numbers actually represent Saturday's numbers. So you can't rely on anything happening on Monday, because it's just not reality. People don't get tested on the weekend very much. They really don't want to think about COVID on the weekend. So we can't start thinking that we're going to see a drop until you start looking at Tuesday and Wednesday numbers. And of course, everyone knows that very dangerous political rally on the weekend on Saturday. So people won't start really getting tested until 2 or 3 days after they've got, and that's normal, after they've got symptoms. But in a protest rally, you may not always have people that are going to be highly cooperative. So if they do get symptoms, they may not want everybody to know that sadly they've got COVID. So, but if they do, we won't probably hear about that until, so about 4 days incubation period. So that's Sunday, Monday, Tuesday, Wednesday. Then give them a couple of days to feel discomfort with their symptoms to then finally get tested. We probably won't know until next weekend. And
So
so
that's about the protest, if I could say. So
about the
in
protest.
terms of whether there's going to be a growth in numbers from the
Yeah.
protest, we'll know that in sort of 4 to 6 days
True.
after the protest. So
Yeah.
are you saying, because when Dr. Chant says in the press conferences, those that are still infectious in the community, but they're doing essential work, is that essentially they are turning up to work, whether it's food packing, distribution? Again, they're not giving us much information about what those kind of roles are. Could they be being done differently? Should they be subsidized?
Yeah.
It feels like we're continuing the same pattern without changing the outcomes.
Quite right. So
does someone go to work, then within about 4 days of that person, that event of that work day, there is then an identification that they may have either been exposed to someone contagious or being contagious themselves, and as a result expose other people? So is everything happening with about a 4-day lag? Or because I know last year we talked about 7 days, so are we at 4 days now? What is it?
There's a 4-day lag, and one of the problems is they've been infectious to other people before they get those overt symptoms. And then there's about, 19% will never get symptoms. So what we need for those essential services, such as truck driver deliverers, people that stack our shelves in our green grocery, in our grocery shops, people that look after us in pharmacy, etc., they are being asked to have a test every third day, but that's not enough, because this incubation period, you're infectious on, some of them are actually infectious on day 1. Not a huge proportion, but day 2, definitely day 3, before they become symptomatic on day 4. So you may actually miss that. And one of the other ways around this, so those PCR tests are great for diagnosis, but one other way around this is to do screening of essential service people every day with a point of care test. Not all point of care tests are good.
Could you explain what that is for everybody?
Yeah. So imagine you've got a pregnancy kit and you put some urine on a pregnancy kit. This is similar, but you put the swab into your nose, just, very shallowly. Some of them are a little deeper, or a throat swab. So there are many different ones. And in fact, there are some sputum ones being developed at the moment. But they can be done with either the nurse at work or yourself with your nasal swab. You don't have to go in deeply. And then before you hop into your truck, that test will tell you you're either positive or negative. And there are about 3 or 4 that are brilliant. You wouldn't do a whole.
And do they work on day 1, day 3, day 4?
Yes.
Because if the current testing we're doing, we're not catching people until about day 4, do these tests catch people on day 1?
These tests can catch them on day 1. And day 2, day 3, day 4. In fact, they're very good at capturing people asymptomatically for the first period, asymptomatically. And PCR are great for symptoms. And they're good for that early phase as well, but they're particularly good for symptoms.
Just so we're all on the same page, PCR is the current testing that's being done. So where people feel a symptom or think they've been exposed or been to an identified venue, they go to the centres to get tested and they get a PCR test.
Correct. And that's what they should do. But if you're screening an essential worker, they shouldn't have a symptom, so they shouldn't turn up for work with symptoms, and you want to catch them before they become highly infectious to others. And remember, we develop 1,000 times more viral particles with Delta than we've ever done with even Alpha. So it finds you early so you can send the person home from work and they stay in isolation. They don't continue to work for another 8 hours, and potentially as that 8 hours goes, you're developing more viral load and you're spreading it to somebody if you're sharing your truck or you're sharing the storage room with your colleagues. So we haven't used that yet, because outbreak management is not just relying on one thing like stay home, except for a lot of people aren't getting that, or PCR. It's a bundling of things. And this particular point of care test would allow people who are essential to go to work and not pose a risk to their peers. And that's what we need. And then when they talk about vaccination, that with Delta won't provide us prevention of infection transmission until you get dose 2. Yes, it'll give you a little bit of protection against death and a severe infection, but it has very little impact on spread until you get it.
So is it, if our number one, so we've got two priorities. We've got the health priorities, avoiding death, so we need to talk vaccination. Second priority, we need to find a way out of this lockdown. And we can't just let it rip. So the question has to be, what additional measures need to be looked at? And what I get from what you're saying is we need that everyday screening of essential workers to be happening with rapid antigen testing. So that's a key part of a way out of this. Would you describe our lockdown as being a strict lockdown compared to what other states have put in place?
No, it's quite light. It's quite we don't have curfews. Now, curfews have worked because it means that the police don't have to check you all the time and they can do their police work. But it also gets into the mindset of people of, oh, I can't go and visit people because if I'm out on the road, the police will ask me why I'm not at home. So it has several really good impacts. So curfews, we have to do curfews. Then that 5 kilometre ring where you can't go further than 5 kilometres helps to contain it. And then point of care testing to allow people to move if they have to. Mask wearing. Now people are not getting, and I don't think that the New South Wales authorities helped people get the idea that as soon as they leave home, they need to put the mask on. I mean, regardless of whether you're going indoors to shop, because this virus is so contagious that you don't need 15 minutes exposure and you don't need that close physical contact. So when I see people walking their dogs, they're walking with somebody else. So I'm hoping that they're a household person, not a friend. If they're a friend, you're not doing your friend any good, not having your mask on. Then they're chatting and people are coming in front of them, ahead of them. Then they pass and you've got two groups that are not wearing a mask. Now, if somebody's chatting, laughing, talking on the phone, the louder we speak, the more forceful our exhalation is, they could get a face full of it, and you don't need that much virus to get Delta. There is an assumption, that, and I just put this out there, there's no evidence for Delta, but with influenza you can catch it through your eyes because you have ACE2 receptor sites. I don't know if people are catching it through their eyes, but wear your mask, maybe wear some sunglasses, but don't talk when you're passing people. Your mask lasts really well when it's dry. The more you talk, the more ineffective a mask becomes because it can get moist and allows particles to slip through. But have a chat, pull it down when you don't see anybody, have a chat, then put it back up. Don't talk, except for if you're in a shop, you need to talk to somebody paying, etc. But wear your mask when you leave home.
So really masks need to be mandatory at all times. Because at the moment, I must say, we do still see a lot of people out and about exercising, but not exercising in a vigorous way that really would say you can't be breathing through a mask. So really, if you're going out for a walk or anything like that, masks really are required.
Correct.
Should be completely mandatory. There shouldn't be a distinction of only when you're going indoors to shop or only in common spaces in a building. And it seems to be quite picky the way we're going about it, instead of just saying blanket masks are mandatory?
Well, the blanket helps people to understand and they don't interpret for their own needs. And people like to interpret. So I've had a lot of people email me picking up the fact that I said walking your dog's not exercise. Well, what I mean is putting one foot in front of the other is nice. I call that movement. And that doesn't prevent you from wearing a mask, because you're not going to have a problem breathing through a mask. So they interpret of I'm doing exercise, I don't need to wear a mask. But they pass shopping areas where people may also be thinking the same thing and placing themselves at risk. So I'm just asking, and it sends a message that they're not caring for somebody else, or they don't get it, or we're not taking it seriously. So blanket rules work, but you don't have to wear your mask when you're out, in some very, very quiet street, no one's around. Just pop it under your chin, and as soon as you see someone in the distance, pop it up.
Okay, so everyone in Warringah, wear your mask. Now, Matthew Ingersoll has put a question up on Facebook, and I'd encourage anyone, if you have questions, please put them up. We've got a number of that have already been sent through, but we have this one. Can you, Mary-Louise, can you explain how vaccination ring fencing is supposed to work if it's done right, and what barriers you see to a successful approach in our current situation?
That's a great question. So the idea of ring fencing has been done for Ebola and other really serious, this is serious, other outbreaks, other pandemics, when you've got a small amount of vaccine supply and you want to get most results for your small supply. So what you're doing is you're preventing or ring fencing and caring for those at greatest risk of death, but not of the greatest risk of spread. And so we've got a classic example here where the 60 years and older have the greatest risk of death and hospitalization. And we know Delta increases hospitalization by twice. We don't know for the young though, because the UK is experiencing most of this and they haven't been able to age stratify and give us ideas about which age are most at risk of hospitalization. But colloquially, when they talk to us, it's mainly the older people who haven't had their second dose of AstraZeneca. So to protect those older people and the people who can't be vaccinated, you ring fence them by a vaccinated group who are most at risk of acquiring it, most at risk of spreading it. And who are they? Globally and in Australia, the 20 to 39-year-olds. So each one of those 20 to 29, 30 to 39 represent about 20% each. That's higher than any other age group. When you put them together, it's just over 40% of all cases. So that's the group you'd focus on. Of course, you'd love to give it to your truck drivers and all those essential services if they haven't already had it. But if they're young and in their 20 to 39, they'll be protected as well when they go out to work. Now, with AstraZeneca and Pfizer, dose 1, and don't forget the young, between 20 and 39, are not at enormous risk of death. Yes, we've had a 30-year-old and it's horrendous, but it's mainly the 60 and over. So the Pfizer and AstraZeneca, one dose, does not give enough protection to that group to stop them from spreading it, because it doesn't reduce their viral load until they get their second dose. Why I've been most supportive of only Pfizer for this group, not AstraZeneca, is that after dose 2, your protection is 88% for symptomatic infections in that group that can spread infection. With AstraZeneca, it's 60%. And you've got to wait for normally 12 weeks, but the government's talking about halving that to 6. That reduces the efficacy, but in the elderly, not a problem. That just reduces their risk of infection. But if they do get infection, they still don't die. they don't get hospitalized at a very high rate. So at a Pfizer, you only wait 21 days between each dose 1 and dose 2. And then you've got really good protection, but your better protection is 2 weeks after that second dose. So all up, that's 3 weeks plus 2 weeks, that's 5 weeks. And that's why vaccination won't get us out of this mess immediately, but it will be our short-term future will. But we need to focus on that small group because we need to give them both doses, because they're still going to, with just one dose, have still a risk of acquiring infection and spreading it without that second dose.
So to stop spread, which is ultimately our way out of lockdown, we need to get that most mobile group, so 20 to 39 or 49, I thought.
39.
20 to 39, double with 2 vaccine shots ASAP, essentially.
ASAP.
And essentially, Pfizer gives it to us in about a 5-week window.
Correct.
Because there's 3 weeks between shots and about 2 weeks to then have the viral load.
Yeah.
So that would give us 5 weeks.
Yeah.
Now,
wouldn't do that till 8 weeks if you're going to shorten that interval period.
Yeah. Okay. I mean, I feel a little frustrated because I recall discussing this with you about a month ago when I was last in Parliament and actually asked the Prime Minister about opening up vaccination for the 20 to 39-year-old group, and I got rebuffed as, that's simply not a priority, but yet clearly in a lockdown situation, it does appear to be a priority to minimise spread. We have also some other groups like teachers, for example, are not currently listed as essential. And so there's a high level of concern and distress around, our children missing schools. So when our children are going to be able to get back to school, but needing to prioritise vaccination of teachers. Do you have any thoughts on that?
Yeah, so last year I was asked that question and I said, the only group that you're at risk out of your teacher is other parents, because that was the wild strain. That wasn't even Alpha. Now this is Delta, and teachers are more at risk of acquiring it from kids. In the UK, 5-year-olds to 17-year-olds have as much of a burden of Delta as young adults. So it's changed. And so I would say to teachers, you are a priority group, just as the essential service group are. Previously, they kept the parents away. Drop your kid off, the kid gets tested for any symptoms, parents leave, teachers are safe. This is not the case with Delta.
So would you say, for example, primary schools is probably even different to high schools? High schools is a higher risk area, and so those teachers should be even prioritised over primary school?
Well, in high schools, I would be doing the 20 to 39 first, and teachers, regardless of what age you are, and then I'd be doing the adolescents, the 12 to 19, only because the 5 to 11 are at the same risk as the 12 to 19 in the UK, the same risk. But if we don't have a limitless supply of Pfizer, then I'd be doing it high school, junior school, high school, to get them through their HSC easily, and then primary school. In that order. But if we had a limitless supply, I'd be going, particularly, we have to check, first of all, on the safety of the 5 to 11. So the FDA in America has approved that recently, and they did a safety test last year, but it'd be sensible if we just waited a touch to see how those kids are coping with Pfizer. But they've been injecting 12-year-olds to 19 for quite some time now, and Israel has been injecting 16 to 19 for quite some time as well. So we know that's
yeah, sorry, I was going to say that is difficult. So obviously those that are resistant to vaccination are even more so when we start talking about vaccinating children under 18, even if it's that 12 to 18. I know our Health Minister Hunt announced that TGA had approved vaccination, I believe, for over 12 now. I've been asked by the media. I must say, it obviously needs to be checked or approved by health, but there is that question of transmission. And when we talk about that 80% of the population needing to be vaccinated to, avoid lockdowns, that's, if we're excluding 15 to 18-year-olds or 12 to 18-year-olds, that's a big proportion as well that are very mobile.
Absolutely. So my calculations since May, when the FDA approved 12-year-olds to 15, I then recalculated because I worked out that, of course, they found it was safe for those adolescents. And then as, of course, the UK was starting to tell us that they were getting more adolescents, my calculations changed, and that's where I had 80% of the 12 years and over. When you put that as a total population, that's about 67% of the total. And it's a big ask. My calculations work on 100% of the 60 and over. Please get your first AstraZeneca if you haven't. Please, please, please get it. And if you haven't had your second, go and get that now. But it is a big ask. But you know what? Australians are very good at taking up vaccines. We're at about 94% of all childhood vaccinations compliance. So they do get it. But mind you, though, some of that has a carrot with it as well. But I think that most Australian parents would realise if they saw the safety and their very good safety results for the adolescents, then they wouldn't want their child to suffer long COVID. And in the UK, they are starting to see more and more kids with long COVID, meaning they've got symptoms.
Could you tell us what long COVID is?
Yeah, so long COVID is where you're still suffering symptoms after 12 weeks. So you don't just get COVID and then, a bit like the flu, 10 days later, get up out of bed and go to work. If you do, you're lucky. But a lot of people still suffer great tiredness, fatigue, fog brain. They're not having problems with loss of taste or smell with Delta, but there are other problems, breathing difficulties, finding it exhausting to getting from the bed to the kitchen. And that can go on for weeks. If it goes on past 12 weeks, it's called long COVID. And there can be multiple organ complications as well with long COVID. It can be mild or very serious. And kids are getting mild, but you don't want kids to have mild long COVID. You don't want them to be exhausted. You want them out on the playing field, causing mischief, because we don't know how long COVID will go for. Will it be their whole life? And we really, really disrespected previously this idea of post-viral depression and post-viral fatigue. Remember the post-viral fatigue that was always thought of as, it's a mental health issue. It's not really a post-viral issue. And I think we really need to understand that viruses can impact different organs. So each part of your body, each major organ has different amounts of ACE2 receptor sites. And some people may have different organs affected because they have different numbers of ACE2 receptor sites. Each adult slightly different. And it's the bad luck of the game to which organ may be most impacted due to long COVID.
So it gets us to, obviously, as you've touched on, well, in detail now, vaccination is so important. We have the difficulties around supply. That's being said ad nauseum. But at the same time, we have a very contradictory message coming from the Prime Minister saying that, look, vaccination is not going to stop the lockdown. And we've touched on that already before, where you were saying, look, essentially it would be 5 weeks. If we vaccinated our most mobile, it's a 5-week period, and then you would start to get that benefit. For those that are vaccinated, though, obviously a question that's come up a lot to me has been vaccine passport, domestic vaccine passports. I have a real problem with the concept of a discrimination internally in our domestically as to freedom of movements according to vaccine. But then there is the incentive for people, if you have received both your vaccines, where are obviously the benefits are personal in that you're not going to get as sick, and you're protecting your family. But a lot of people are asking my office around, should people who have received the vaccination or employers who are encouraging and enabling vaccination have some benefits, like being able to work and do other things?
Well, first I agree that a vaccine passport has a lot of human rights issues involved in that. And I'm not a human rights expert, but at WHO we're reminded to constantly think every time you make a statement or a rule around something, you have to think about how this can impact across a multitude of people and their inabilities, for example, to get vaccinated. So the idea of, can vaccinated people go to work? Yes and no. It could work, but don't forget, the vaccine is not 100% protective. Now, you may be somebody who's had a vaccine, 2 doses. I've had 2 doses of AstraZeneca, but I may be that small proportion who may still acquire infection, but I won't die. So that means if I acquire infection, I can still spread it to you if I go to work with this special vaccine passport. And that's why we need herd immunity, so that if I can spread it, the person I'm most talking to, for example, has been vaccinated and is protected, won't get it. And then they protect also that next layer of people who couldn't get vaccinated. But the way around that is to do point-of-care testing at work. And that's what the UK are doing. So if you work for a large company that have, for example, open office space, etc., and you have circulating virus uptick, then you go to work and they test you on the morning and you're fine, you go to your office. So we could do and in outbreak management, you don't just have one thing that works, you have multiples, so that you can catch an escapee virus. So I can go to work, I have the vaccine, but I might be carrying a low viral load. I don't really realize it, and I give it to some person who may not have been able to have the vaccine at work. That's not good. But if I go to work vaccinated and I get a rapid antigen test as I'm entering the university, and that way I'm protecting all of the young people as well, who may have been vaccinated and still remember that, I think it's about 18% won't be protected from a circulating virus. I'm protecting them, so we do double.
So if that the screening of essential work, that point of care testing, and that's happening in the UK, but as I understand it, that's not happening in Australia at the moment. And do you understand or have any information as to why?
So in the UK, they were giving out rapid antigen tests for free. So you could have, each household could have 2 in a week. But in large organisations, you would get tested every day. You could pick them up at the library as well. And we aren't doing it here, but I have heard that there are workplaces that are. And they're possibly getting their kits from a rapid antigen supplier. And as I mentioned, there are about 3 or 4 of them that have really superb performance, and doing it as a trial. So they were using these at Howard Springs. The man who was running Howard Springs, Dr. Ian Norton, ex-WHO, brought them in. I think the Northern Territory have decided not to use them because now the government's having to pay for that addition of that test. Now they're only about somewhere between 5 and say 15 Australian dollars. But they're not going to get any rebate from the government, and yet the PCR test is rebated at about, I believe, about $100. And so there's a disinclination of governments to want to pay for that extra test called PCR, or point of care testing, rapid antigen testing or point of care testing by your work authorities, your line manager, because it might need to be paid for. But the cost of that compared to the cost of lockdown, which is $1 billion a week, is minuscule. And I don't understand the reticence to add focused, frequent testing that if you miss somebody one day, you will pick them up the next or the next. I just don't get that. They're still thinking diagnosis. They're not thinking outbreak management.
So, but New South Wales is currently, for example, essential workers are being required to be tested every 3 days, but that is still not this rapid point of care testing. That's still the PCR test.
Yeah, so they're still doing PCR tests every 3 days, but don't forget this incubation period is shortened, and therefore they're infectious. They could be infectious between those, day when they've had it, and then another couple of days they could be infectious to others. So the tradies need to be tested every day. Now they can't line up in their car for hours to be tested every day. They just can't. But if they're self-employed, they could be given a take-home test, and they could legally be obliged to put the result up. And if they find that they're causing an outbreak because they've been putting up the wrong result, they could be fined. But, you can be negative one day falsely, but although the false negatives are incredibly rare with these things, it's more likely a false positive. They get a false positive, they go and get a PCR test immediately, and then they can go back to work the next day if it's negative. So they can do it at home. And then those that work for places like Lindsay Fox or Woolworths, Coles, IGA, or Priceline, their boss tests them as soon as you turn up for work. Pull down your mask, get tested. 15 minutes later, you get a free pass. Great, go into work. You're safe, and that should be done every day, and that way you're safe every day to your colleagues, and that way we could open up, incrementally, and of course getting people vaccinated, and then using those tests when there's all of a sudden escaped virus from quarantine could also help.
So I did have a question from David Beauchamp, who I believe in our chat, who is saying on Facebook, so what's our ideal roadmap out of this crisis? A magic wand, but other than that, I think if I'm talking from a Sydney base where we are in lockdown, and at the first, for the foreseeable future, we have several weeks more of lockdown as it looks like. What would your roadmap out of this current crisis that we're in be?
Well, it needs to be focused, and also focused frequent testing, scattergun testing as well. So you can't just rely on people with their good nature turning up and standing in line for hours and hours. It would be opening up multiple areas where you can get vaccinated, your local government, your pharmacy, which is slowly going to be doing that, any testing site. So you could have a PCR test if you've got symptoms. You go to one clinic. If you've got no symptoms, get rapidly tested, and it's negative, go and get your vaccine at the same time. We need to be, and take the vaccine to your workplace when, well, most of us can't go to a workplace, but for those who are essential, they test negative. Would you also like a Pfizer test with that, or a Pfizer vaccine with that? So we need to double up and increase the speed at which we're able to get out of here. But it has to be bundled, and we have to have long and short term thinking as well, and just different thinking. We keep doing the same thing over and over again, but we're not getting a different result, and we're not realizing that the strain is different. So when I asked for an early lockdown and the government said, well, we don't need this, our contact tracing's great. The contact tracers, imagine them, the contact tracers are good, but they're like running towards hopefully getting to where the virus hasn't gone. But the virus is so fast with this one and so infectious, they're never going to get to people before it's spread. So contact tracing is only a secondary prevention. It's not a primary one, and it's been used as primary previously. But really, yeah, vaccine is a primary one, but keeping each other away and doing testing at the workplace for essential services also will help to eventually open up.
So something I'm very keen on is, comparing your work towards being reactive, so responding to a situation, which very much fills the situation we're in, and proactive, which is going out ahead of it, looking for where the outbreaks could be or situations. So proactive would be point of care testing at work. The reactive is the PCR and all of that. Proactive is getting vaccinated and getting that vaccination to the groups that may not be the most at risk of health yet, but they are the ones at risk of spread.
That's right. And reactive is expecting people to go get vaccinated. I mean, one of the most successful things in Israel was that you got a WhatsApp message saying it's time to be vaccinated. I mean, I got a phone call, which was wonderful, from my GP saying, come and get your vaccine. Oh, by the way, come and get your second one. But that's a lot of hard work. And not everybody has a GP. I mean, young people, when they leave home, leave their family GP and have got nobody. And some GPs can't take other GPs' patients to be vaccinated. So we need to make it easy for the young ones, front up to work with the vaccination trolley. In hospitals, the way they got healthcare workers to start uptaking the influenza vaccine before it became mandatory was actually be in the foyer or go into the wards. And then they took it up, and they used to be called, trolley dollies, with a bit like the crew, the cabin crew, would you like a Coca-Cola with that? And go out and actually be there so that very, very busy healthcare workers didn't have to think to look after their health. And that's what we need to be doing, proactive vaccination.
Aspect. But again, we have that difficulty of that younger, we haven't, I know probably close to out of time, but we haven't touched on that change of advice from AstraZeneca in relation to AstraZeneca versus Pfizer. Do you want to touch on that a little bit? Because obviously we now have open to all age groups, you can go to AstraZeneca. Obviously get advice from your GP, but could you just talk through that change of advice from AstraZeneca?
So I'm going to be very provocative. I don't believe anybody under 60, if you've already had your first dose and you're in your 50s, nothing happened, then your second dose, you're very unlikely to have an adverse event. So get that second dose. Don't waste that priming of your immune system. Go and get that second dose. Everybody else, get your Pfizer if you're under 60. Why? Because the data haven't changed. You are still at the greatest risk of the 18 to 49. You have 3 per 100,000 risk of a clot and a very serious clotting syndrome than those over 60. And those between 49 and 59 have a slightly lower risk than the younger group, but it's still a high risk. Now, normally, when governments approve medication and vaccines, they give a buffer zone of safety, but they didn't this time because it was a pandemic. Now we have a buffer zone that says you can't get it if you're under 60 or you shouldn't. That hasn't changed. So get your Pfizer.
But I thought it had changed because we're now in a lockdown. We have a higher rate of cases. We have, sadly, the most recent decease was quite young. Mm-hmm. So when you weigh up those risks, your risks from the consequence of AstraZeneca are still much, much more remote than risk of contracting Pfizer and risk of contracting COVID and having long COVID and all sorts of other consequences.
Now, that is true, but you haven't factored in the risk of the fact that AstraZeneca has a lower efficacy for preventing you from having symptoms. And because you're in that youngest group, you need to be protected from acquiring symptomatic infection and passing it on. So that young group between 20 and 39 should not be having AstraZeneca, they should be having Pfizer, because it gives you 88% protection from symptomatic infection. You are at very little risk of death and hospitalization so far. Okay?
So the main goal is if that group gets Pfizer, we get the most effective way of stopping spread.
Correct. Yes. So that's why
Don't have enough.
Yeah. So that's why I don't, if we had enough, and that's why I still don't support the change in the ATAGI approach, because I think that it's a panicked approach and the data haven't changed, but the epidemiological data show that the 20 to 39-year-olds need to be protected from infection, and they're only going to get the best one from Pfizer.
Okay. So I think I had one last question, which was, is it possible to having mobile vaccine? I mean, you've sort of touched on mobile vaccination, getting vaccination at points of work, at people's homes, for example, at schools, for teachers. Is there any real barrier for that?
I think it's a great idea, particularly the Pfizer for the younger ones. You don't have to then be thinking about your medical issues if you're young and you want AstraZeneca, because you'd have to talk to your GP about that one. But I think that mobile ones are a great idea. You still have to give an informed consent, but that's easy enough to do. They can have the hard copy, a bit like the mobile chest X-rays that used to go around when I was a kid where I lived. So yeah, absolutely, we could have those, and we could also have mobile testing.
Mobile testing as well, yeah. Well, look, I know a lot of people in the Northern Beaches would love me to be able to say or ask, could the Northern Beaches be removed from the current lockdown? But unfortunately, we have seen that it spreads incredibly fast. I don't expect a positive answer from you for that one.
Yeah, it's sad because if the Northern Beaches were to travel to the east, and then you're so interconnected in the Northern Beaches, if you brought it back, it could be devastating. So sadly, we all have to be in this lockdown, whether it's light or hard, together until we get that number down. And even if you've been vaccinated.
So this is very much the change situation of Delta, which the Christmas lockdown was not Delta. Are there any other variants developing or emerging around the world? I hate to ask that question, but again, in trying to be proactive,
At WHO, we're having a meeting very soon about variants on prevention and control, and certainly Delta has been the biggest problem, but the next one coming up is Lambda, another problem in Peru and South America. So if we get return travelers and family and residents coming in from South America, they have to be very, very careful to contain it. So we really do need a vastly improved quarantine system.
Yes. Well, yes, the fit for purpose quarantine facilities rather than hotels for tourists.
Definitely correct.
Okay. Mary-Louise, I know I've taken up a lot of your time, so thank you. So many people really appreciate it. Everyone, if you have more questions, if there's areas we didn't touch on, please let me know. I can pass them on to Mary-Louise and try and get some answers for you. More importantly, I will take up some of those suggestions of roadmap, put forward and write to the Prime Minister, to the Health Minister, around these suggestions that we need to keep looking for solutions. But lastly, to everyone in Warringah, please take care. This is really difficult, frustrating. A lot of people are anxious, and economically this is having a huge impact. Local businesses are really, this is so damaging and hurtful. And we need to look for solutions. So I really appreciate all your feedback and insights, Mary-Louise. Thank you.
It's always a pleasure, Zali, and happy to answer any questions that you receive. So stay safe, everybody.
Thank you.